Today we are going to talk about mood disorders. Try and imagine a life without mood, a kind of a flatness, a kind of no highs, no lows, just a flatness. Such a world cannot exist. So we are, the Homo sapiens, rich with mood. We can be very high if we're windsurfing in Mauritius, and we can be very low if we lose our favorite dog. So humans have a huge width of variations of mood. We can be very high and it's still normal. And we can be very low, which is still normal. So immediately I want to reiterate the fact that we must accept the normal range of mood. It is very important to differentiate between what is normal and abnormal. A bereavement reaction is a normal thing. If I've lost a loved one, it is not just a little bit bad. It is terrible. The worst thing that can happen to you is to lose an adult child. The bereavement is shattering. It is painful, not for a day or two, for weeks, no, for months, no, for years. But as long as the bereavement reaction is completing, going through the different stages of bereavement, it is still normal. So what I'm trying to say is that human pain is part of our life, and we should not make what is normal abnormal. With normal bereavement reaction, I always tell my patients, eyes that have cried can see better. Bereave, experience the pain, and it will go better in the end. So what is abnormal mood? Abnormal mood is where the depression is way down here and where the euphoria is way up there. I always tell my patients the difference between a bereavement reaction. A bereavement reaction is like it's full. It's a full, painful feeling. It's stormy. It's a full thing. But the abnormal depression, the major depression episode, the patients describe an emptiness, a void, an emptiness. We are going nowhere. This is too late. It's a different in quality of a mood. I must just do a list of mood disorders. What disorders are there? Now, the first one is not a disorder, and that's normal depression, and it can be quite low, like in a bereavement reaction. Very painful. Don't tell me you eat and sleep fantastic when you just lost a loved one. So a normal depression, we've got to sort out what is still within the boundaries of normal. Then, number two, we get to the bipolar disorders, and the bipolar disorders is, there are two or there are four, but a bipolar 1 disorder is where the patient would get very manic, normally, so that you have to admit him, delusional, grandiose. Bipolar 1 is where the mania is severe. Bipolar 2 is where they don't get manic, they get hypomanic. Hours or days of just above the line. This is not the person, him or herself. So that's a bipolar 2 with hypomanic episodes. And we often miss those. We often miss the bipolar 2s because we don't ask for them. So the bipolar is high or very low. Number 3 is the cyclothymic disorder, where you get short bursts of high and short bursts of low, more rare. And then you also get substance or medication-induced bipolar, where a stimulant would make you manic. So where the substance or medication can make you manic or severely depressed. There's lots of medications that can make you severely depressed. So we must always sort that out. Is this a substance-induced disorder? And then, of course, medical conditions. For instance, hypothyroidism, myxedema. Myxedema can just look exactly like a major depressive episode. But then you must treat the major depressive episode and you must treat the hypothyroidism, the myxedema. So those are the bipolar spectrum disorders. Then number 3, we get the depressive disorders. And the depressive disorders, there's 2 new kids on the block that I want to tell you about. Disruptive mood dysregulation disorder. This is children between the age of 6 and 18. Children does not complain about feeling depressed. They become angry, they have temper tantrums, they have temper outbursts, they're irritable most of the days, more than what is normal, and this will go on for more than 12 months. This is actually a childhood persistent depressive disorder. So that is the new kid on the block. Then major depressive episode. Depression is still underdiagnosed and still undertreated. Then we get the old number 3, the old dysthymic disorder. That is the persistent depressive disorder. Previously we called it dysthymic disorder, and it's very common, 5 to 6% in the population. Then number 4, we get under the depressive disorders, we get the premenstrual dysphoric disorder, where there is a very low mood, a depressed mood a week before until a week after the menstruation, with all the severe depressive symptoms. Then number 5, we get in substance, medication-induced depression. We know that the stimulants will eventually make somebody severely depressed. And a depressive disorder due to medical conditions, and I've already named that the hypothyroidism. Let us get back to the one that we must have a good knowledge on, and that is the major depressive disorder. One can have up to a third of people will have one major depressive episode in their lifetime. Unipolar may be recurrent, or a major depressive episode might be part of the bipolar disorder. Again, why do people become depressed? You know, we've got in the community, we've got to say, don't put up a face like that. Life can't be that bad. In Afrikaans, ruk jouself reg. It's not like that. When you get to a disorder of depression. Why do people become severely depressed? Again, the genetic predisposition. Again, the stress can eventually break the camel's back. Physical illnesses, chronic pain disorders can make you severely depressed. Substance abuse, especially the stimulants and the suppressants. And there can be combinations of this that can cause a major depressive episode. So what is a major depressive episode? You are depressed every day, most of the day, for more than 2 weeks. And there's a loss of function. They stay in bed, especially in the morning. They cannot get up. There's a suicidal risk. It's an ongoing, and the quality of the mood is a kind of emptiness, not this full, painful thing. It's a kind of an emptiness which is very, very bad. Major depressive episode is very common. There's a lifetime prevalence of 12 to 16%, twice as common in females than in males. When do you get your first major depressive episode? Mostly between the ages of 20 and 50. What are the symptoms of a major depressive episode? Ongoing depressed mood every day for more than 2 weeks. It's an emptiness. Anhedonia. Anhedonia is a word that we use in psychiatry all the time. Is the inability to experience pleasure. nihilistic, means a self-image. I am rotten, I am bad, a nihilistic feeling about self, and this will happen most of the day. It's worst in the morning. There's what we call a diurnal swing, worse in the morning, better in the afternoon. Poor concentration, the thoughts are negative. This country won't make it, this world, the ozone layer is going to kill us. Everything is negative. It's half empty, the glass is half empty all the time. Negative thoughts. I'm a bad father, I'm a terrible psychiatrist. Negative thoughts. There's no energy. The energy can be two things. We get the agitated major depressive episode, they agitated, and those are the people that really can commit suicide successfully. And you get the psychomotor retarded kind of depression, the one that they don't get it, they're actually retarded. And then with this also, appetite is gone, they wake up in the middle of the night, the libido is down, their weight is down. It can be, in the atypical, the opposite of that. But mainly poor appetite, poor sleep, poor libido, and weight down. This is more than 2 weeks, and this may last for months if we don't treat it properly. And what is so wonderful about this, it can successfully be treated. And if you treat a depression, it's not like treating a headache. You cannot take an antidepressant and you feel well the next day. An antidepressant takes 3, 4, 5 weeks before it really kicks in. And then you must stay on that antidepressant for at least 1 year, because depression seems to us as a serotonin shortage. But you cannot just push it up today and you're happy tomorrow. There's a cascade of reactions within the brain. How do we treat a depression? I just cannot give you a serotonin drug. Give you a little bit of serotonin and you'll be fine. No, there's always psychoeducation. There's always psychotherapy. And you must teach your patient, and this is difficult, you must teach your patient to take ownership of illness. If a patient is a victim of a disease, they will not get well. But if a patient takes ownership of illness, they will get better. So it is a major depressive episode we treat with antidepressants plus psychotherapy. If it's stress related, of course, manage the stress with psychotherapy. If it's genetic, then it might happen again because I'm genetically predisposed. Then the treatment is going to go on for many years if it's a repeated genetic thing. If it's substance abuse, if I get depressed because of substances, I've got to treat the substance abuse. I've got to give for rehab. You cannot give an addict just antidepressants and no. So you must treat the substance addiction plus you must treat the depression. If it's a physical illness like myxedema, you must treat the hypothyroidism plus give an antidepressant. So mostly to treat a major depressive episode is psychotherapy plus antidepressants. There are many, many antidepressants. The old tricyclic antidepressants, they're lethal in overdose. Very seldom we use them today as psychiatrists. We still use them in very, very resistant treatment to depression. Then there's the tetracyclic. Then there's the family of SSRIs. The SSRIs is selective serotonin reabsorption inhibitors, and there's lots of them. Then there's the NSRI, which is noradrenergic serotonin reabsorber inhibitor. Then there is mirtazapine, propulsion, trazodone, reboxetine, and the new kid on the block, it's the first non-monoaminergic drug, agomelatine or valdoxan, which is a kind of a growth hormone drug. So antidepressants in pregnancy, maybe just one word about that. Up to 8% of pregnant patients use antidepressants. It seems to me that if you do not treat the depression in pregnancy, you've got a 68 to 75% chances of a relapse. If you continue the drug, only a 26% relapse. So sertraline is the drug at the moment with the least placental exposure, and then we use fluoxetine. But the SSRI seems to be safe. If we as psychiatrists and doctors, GPs, make the diagnosis of a major depressive episode, then we're going to ask family history. That will give us an indication whether it's genetic, whether it's a genetic vulnerability. We will ask if there is a previous episode. That will also make us think about a genetic component. Then we must ask, was there ever a hypomanic or a manic episode? Because then it becomes a bipolar illness. Then we have to add a mood stabilizer. Then if there are obvious stressors that is the cause of the depression, then we must manage the stressors in psychotherapy. If there's substance abuse, we must of course treat it. Over-the-counter tablets, lots of problems with over-the-counter tablets. There are a lot of the painkillers that would make people severely depressed, so we've got to have a good look at that. And then a psychiatrist, I am not only a psychiatrist, I'm a medical doctor. Therefore, I have to do a physical examination to make sure that this illness is not because of a physical illness, and I have to do a few special investigations. And then one of the main things about the treatment of major depressive episode is compliance, compliance, compliance. If you get your patient to take the medication, you're in the pound seats. Now, when we get to the treatment of bipolar and manic disorders, hypomania, sometimes in the bipolar 2 disorder, the hypomania is not detected. We don't pick it up. Therefore, I must teach the doctors to ask for those hours and a couple of days where they are just a little bit out of it, so that we can make the diagnosis of bipolar 2. If there is a clear manic episode, we must add a mood stabilizer. And the number one mood stabilizer is still lithium carbonate, but there are other drugs, sodium valproate and other drugs that we must add to the list of treatment for the bipolar. A hypomanic episode may still be tolerated in the community, but when a patient gets manic, they are quite self-destructive and also a huge burden to the community. And they most probably must be admitted to a psychiatric hospital, and one must make sure that they've got the understanding, competency or capacity to make that decision. But for their own benefit, they need to have inpatient treatment, and we've got to start them on a mood stabilizer, and then again follow up, and we must make sure that the patient take their medication. I thank you.